Thank you, everybody, and it's great to see people all in a nice and cozy room here when the weather is so yucky outside. So thank you for sticking around for this afternoon. So first off, I have to say I'm Juliana Wu. I'm from the Canadian Institute for Health Information. Really delighted to be here on stage with you. I was really keen to share the stage with my colleague from BC, Monique Rasmussen. They have done some really wonderful work leveraging assisted coding solutions out in BC under Providence Healthcare. But unfortunately, Monique has fallen ill, so she is not here today. So you only got me, so I'll have to pivot a little bit. I will tell you a bit more instead about CaiHi's work, our transformation journey, what we're doing in the hospital space, and of course there'll be lots of time, hopefully afterwards, to hear from you and for your questions and comments. So let's get started. A little bit first off about CaiHi. So I know this room, CaiHi is not an unfamiliar name. Many of you know what we do. The Canadian Institute for Health Information, we are a pan-Canadian data organization. We're specialized in collecting, enriching, and reporting on hospital data and other sectors of data across Canada's health system. So currently we host over 28 different data holdings, all of them pan-Canadian. And in our role, we steward over 10 billion records. So out of those 28 data holdings, over 10 billion records, and largely these records are linkable at a person level. So you can imagine how rich that data can be in terms of supporting care decisions and also informing system management and care and quality improvements. But I would say that CaiHi is also not just about data. So oftentimes we think of ourselves as a data organization, but really we're more than data. Our goal here is really quite simple, as you can see, is really to orchestrate a connected health data ecosystem in Canada. So that's actually broader than data. There's lots of other pieces that would need to have to be in place for a connected health data ecosystem to exist across our country. So imagine we have lots of data, but if the data gets sitting in a repository and it's not being shared, it really defeats the purpose. So our goal here is not only to collect and enrich and make sure the data is high quality, but make sure that the data can be shared ethically, responsibly, and efficiently as well, so that the right information can get to the right people, the clinicians, the patients, at the right time. So to do that, and that's part of our transformation journey over the next few years, is to really create a foundation of what this connected healthcare system would require. You can imagine the development and the modernization of data standards that can be used at the point of care, and that same data standards that can help data to move more seamlessly across systems, getting it to patients, getting it to clinicians, and also making sure the data is used responsibly. I know we've heard in quite a few sessions yesterday and even earlier this morning that just data, standards, and technology is not enough. We also need a whole umbrella of data governance and stewardship framework to make sure that we are using the data appropriately. There's consistency in the way we use data, and there's a healthy respect also for data sovereignty, accountability, and trust. And so these are things that I think you've hearing about CaiHi engaging in around connected care, around standards, and around data stewardship. And then last of all, of course, even with data is connected and is moving seamlessly across system, we continue to want to generate system insight. And that system insight has to be available at the system view, not just siloed in hospitals or in primary care, but at a system level, and also making sure that that information is made available as timely as possible. And with all those pieces together is when we can really look towards better outcomes for our patients, for Canadians, and a healthier community. So that's a little bit about CaiHi and our transformation journey. So I would assume that as you go forward, you'll hear more and more of our activities around stewardship, around connected care, and system view. So now I'm going to bring ourselves back to perhaps the focus of today, which is hospital data. So just from being in a few sessions today and yesterday, I know this room is no stranger to our hospital data sets. So you've either worked in a hospital or you're working with data that's generated from hospitals. And you would know that CaiHi currently have two very comprehensive hospital data sets, the DAT and the NACRS that our previous speaker just referenced today. And the data NACRS, I have to say, must be one of the most comprehensive source of hospital data in Canada today. Again, reinforcing the idea that it's pan-Canadian, and it's truly comparable across the country, it's standardized, and it's linkable. And it's heavily used. Like, we know how much people are using our data NACRS data in and out for policy making, for decision making, for funding decisions. But I think everybody in the room also know that much of the data, as well trusted and as high quality it is today, is also retrospective. So we really have a data latency challenge in our data NACRS today from a reporting and from a use perspective, right? So as you know, oftentimes the patient had already received the care and had already been discharged from the hospital, and it's another 2 or 3 months before that data actually becomes available for use at a system level. So we think about what drove that kind of data latency challenge. I would say it's 2 things, right? It's outdated systems. So honestly, data NACRS dates back many years ago, and also outdated processes, because much of the data compilation and coding process really dates back to the analog stage, right? It's really based on that paper abstract paradigm. So as we're thinking about and reimagining how we're going to do hospital data collection today, we're really looking for opportunities for either existing or emerging solutions for us to source data faster across the country, but also looking at how do we practically alleviate the burden on our coders, both in terms of work burden, but also the cost burden on the continued collection of hospital data. So those are the 2 pieces and 2 problems, essentially, that we'd like to solve. Which brings us to our Hospital Data Transformation Initiative. So with priority funding from Health Canada, CAIHI right now is in the 2nd year of a 4-year journey to really reimagine how we flow hospital data across the country. And we're really trying to do this based on 4 guiding principles. Guiding principle 1 being to leverage the extensive investment that has already been made into digital health solutions across the country. We know many hospitals nowadays do have their own hospital information systems. Some are also implemented provincially at a provincial level, right? So those type of investments have already been made into our hospital as we speak. The second guiding principle then would be to leverage the very rich data that is already being collected and generated in real time in these hospital information systems. So we're not creating anything new. We're just trying to leverage what's already existing and what hospitals have already paid for in a way, right? Solutions to capture this data in real time. The third piece, though, it's a little bit of identifying new solutions and new technologies that can really help alleviate the coding burden on our coding staff. We know these solutions exist and really looking to make sure that the data collection is less burdensome than it is today. And then lastly, to also make sure that whatever we build today is conducive to health data portability, making sure that as we create new hospital data flows and new hospital data standards, that these standards are well aligned with our interoperability and connected care goals. So if we think concretely what that means, this is our reality today, and this is probably not, nobody's kind of foreign to this picture. Essentially, what happens today is the patient gets their care in the hospital, the patient got discharged, and then literally in most hospitals, and I think some hospitals can do better than others, but essentially there is a lag in waiting for clinical data documentation to even be completed in the first place after the patient has been discharged. After that, oftentimes coding departments will have to wait for a coder to become available and be assigned a chart so that they can start and go in, review the charts, reference different sources of information, standards, coding guidelines in order to do the coding and data compilation for it to be submitted to CAIHI. So like I said, right now we're seeing a 2 to 3 months kind of delay or turnaround before the data can be made available for system use purposes. So where we'd like to get to, though, is that in the very near future, we'll be able to get at least some of the data on a daily basis, and possibly for some pieces of information in terms of hours and in days and not in months. So we're going to do those in two ways. So one is we feel like there's a lot of very rich information that can be sourced directly through data exchange with near real-time or real-time data exchange with hospital information systems. So imagine what's being captured today in ADT system, for example, admission discharge transfer systems. Lots of information about why the patient came to the hospital, where they're moving between units, where are they staying. That information can come to CaiHi in real time. Now, but that in itself is not enough. So we're going to supplement that subset of near real-time data with the high-quality coded and abstracted data that we've been getting in the data in ACRIS today. Now, ideally, with adoption of some of these assisted coding solutions, that process could be faster as well. So then instead of months, we may be talking about weeks. So overall, we're expecting through this kind of paradigm shift to be able to see a lot of the information available at a pan-Canadian basis within days and not within months. Now, so if you look at this picture, if you imagine like the blue squares, or I think it's coming up as blue, the abstracted data is the data in ACRIS that we have today. We're going to be enhancing the minimum data set in those databases because we know those data sets are also developed years ago, so there's an opportunity to enhance and modernize what we collect in the abstracted and coded data space. But really on top of that, and what's going to be new, is this near real-time exchange with hospital information systems, so that we can really report on data from yesterday, for instance, around who came to the ED yesterday, for what reasons, and who were discharged, and be able to report on some very high-level discharge and length of stay information. That's the goal that we want to get to. Now, so of course we know, and then we're starting to have lots of conversations with our partner hospitals to explore that near real-time data exchange mechanism. But we know in the course of those conversations that the data captured in HISs are very different. They're going to be very different and very messy, and a ton of data being generated in these clinical systems. So then there's a whole lot of work, I think, for CaiHi to learn and to figure out how to do the transformation and essentially normalizing of the data from these ADT systems to get it to fit for use and fit for our analytical purposes. But we know that these kind of technology exists. Lots of technology would be able to help us to take in the ADT data, for instance, be able to parse the information, de-identify it, normalize it, and then map it to specifications so that we can feed it to our downstream reporting and analytical processes. So really interested in that space in terms of what kind of tooling out there could be helpful for us. Now, the other thing also is we recognize that if we're getting near real-time data in from our hospital partners, then we should be returning new value add to our hospitals and to our ministries and other stakeholders in near real-time as well. And what does that new value add look like? What kind of new metrics and measures would be helpful for our hospitals and for the ministries so that we continue to provide them with relevant and actionable information in real time? Those are the discussions that we're having with our partner organizations as well, because we firmly believe that we need to be co-defining those things as opposed to developing it individually within our own little silo. So moving a little bit on to the assisted coding space. So earlier I mentioned that we're exploring a lot of technologies. We know technology exists out there, an automation tool exists out there to make the whole data collection and compilation activity a lot simpler and less burdensome. So this is an area where it would have been nice if Monique was here, because she is really the coding expertise that we would really rely on this portion of the talk. But I'm happy to share with you what we've been doing to date at CaiHi. So in particular around coding, and by clinical coding I mean the process of going into the patient charts, identifying perhaps information around the patient's diagnosis and intervention and what kind of medications they were prescribed in the hospital, and turning it into coded information that can be used for analytical or statistical purposes, right? And that process could be identifying the appropriate ICD-10 CA codes and CCI intervention codes so that it can be tracked in a more systematic way. Now, as many of you know, Canada also has very unique coding needs that are different from other jurisdictions. Our CA version of ICD-10 does have its specific requirements and specific coding guidelines that our coders are have the expertise in making sure that they captured it in the appropriate way. So when we look around the market, we know that there are solutions out there. There are many AI-assisted solutions that would be able to identify key text in the chart and then convert it to codes, for instance. But not many out there actually meet the Canadian coding requirements. So for example, a very specific requirement for Canada, for coding Canada is typing a diagnosis. And that kind of diagnosis typing approach is not available in other jurisdictions. As in internationally. So then when you look at these coding tools, and much of these tools are developed outside of Canada, so they wouldn't immediately be able to meet our Canadian coding needs. So what we'd like to do, and we've been just embarking on this journey, is to really understand what the market looks like, especially around the computer-assisted and autonomous coding space, and also thinking about how CIHI, as a pan-Canadian standards organization, can promote and accelerate the adoption of some of these technologies and really grow the market in Canada. So to do that, we're doing a couple things. One is we are very excited to have launched several what we call discovery projects to test out these assisted coding solutions. So essentially is we have some funding available and we provided fundings to several partner hospitals and also health authorities for them to trial some of these coding solutions. And our goal is that through that experiment and through that implementation, CIHI would be able to learn about what is required to implement this type of technology into Canadian hospitals. Where are some of the gaps? Where are some of the improvements that we can potentially bring it back to the vendors on? And also alleviate some of the procurement process in terms of developing implementation guidelines or evaluation framework that would help others who are other hospitals down the road who's interested in adopting these technologies to have an easier procurement and selection process. So these discovery projects are underway. We're very excited about the findings that will come out towards the end of this fiscal year. Now, the other piece, the middle piece around coding quality study, this is a little bit of something that we're doing internally at CIHI. And this is a little bit of kind of forward thinking because we anticipate that as hospitals begin using more of these technologies, that we would see changes in the patterns of data that is coded into our hospital system and into our hospital databases. So what we're doing right now is establishing some type of a baseline, essentially, is to start monitoring and tracking what the coding looks like right now in our data NACRS. And as more hospitals gets onboarded into these technologies, we would start seeing and be able to attribute to any changes that is attributable to the adoption of these new technologies. So it's some foundational work that we like to do to prepare for that new technology being widely adopted. And then the last thing, of course, is CIHI also holds our classification standards, so we do know we hold the ICD-10-CA and we have our coding standards. So also making sure that our products and our Canadian coding standards, for instance, are enhanced in such a way that can be better integrated into workflows that is, appropriate for digital solutions. As you might know, coding standards has been, a lot of our documentation has been PDF-based. It's not easy to use or implement it into these vendor solutions. So we're doing our enhancements work on our end as well to kind of keep up with the times in that sense. So, just a couple of key findings, and again, Monique would have done a great job talking about what are some of the learnings from adopting these new solutions, but I think it's also not surprising to know that, change management would be key. So Monique and other hospitals that have been on this path already would say that we needed leadership from the top, right? And also there's a lot of cultural change as well, and making sure that our HIMSS professionals, our coders in the hospital recognize that this is not a replacement of their work, but be able to redirect some of the more routine coding exercises to the solution, and so that they can be more dedicated to more value-add and complex coding scenarios. So hopefully this is a different way of doing things, but really the change management has to come from the top, and also needing very good and strong project management structure to ensure the software is implemented and that the implementation can go smoothly. I spoke a little bit about evaluation framework. So this is something that we think CIHI can hopefully be very helpful to the hospital community is once we have a good and solid learning of where the capabilities are for these solutions, we are defining an evaluation framework so that hospitals can pick up and use in when they start thinking about which solution to adopt. And there's multiple dimensions that we're considering for this framework. So it's not just about how easy it is to implement the technology, but of course also about coding quality, code efficiency, and just as importantly, coder satisfaction. So how easy is it for coders to start using this new tool? Is it kind of interfering with their workflows? That kind of assessment. So our goal is that towards the end of this year, when the discovery projects are done, we'll be able to craft up a very kind of solid evaluation framework that can then be used broadly across other hospitals who are interested in trying out these solutions. And this would be my last slide. So, we spoke a little bit about hospital systems, near real-time data, and then promoting new technology around AI-assisted coding. And none of that, of course, could be done by CaiHi alone. As usual, we work very collaboratively with many of our partners. But health system collaboration here is, of course, we often work closely with our hospital partners, with our health authorities and ministries of health, but also increasingly with our patient partners and just understanding what it means to create a modernized hospital data system that is part of the greater Canadian health data ecosystem. But increasingly, too, we're also working with our private partners, like partners from the private sectors, because so much of this work is also understanding what expertise and what innovation has been out there. We're wanting to get a good understanding of all the different vendor products that's out there, either around AI-assisted coding or even on hospital systems and clinical information systems. And the data exchange as well is lots of new possibilities and new options there. And then, of course, we're also working close with some of our PCHOs, the Pan-Canadian Health Organization partners, such as Health Infoway, who is working alongside us around the Connect to Care initiative. And CHIMA is a great partner for us as well. So CHIMA is the Health Information Management Association. So they're keenly interested and really share our interest in and having their coders explore different ways of working and really be able to augment the work and the type of contributions that the HIMSS professionals can make in the hospital space. Last but not least, I will highlight our partnership with Gemini. So you guys may also be familiar with Gemini. It's a research network based out in Unity Health here in Toronto. They have been working and they have been starting to really explore how to also source near real-time data just in the context of Ontario, but essentially sourcing clinical data as well. So you think about data and accuracy as pretty administrative data that we have to date. They're interested in getting at clinical data, things like vital stats and other kind of more clinical information. And so we see a great synergy and potential opportunity for us to learn alongside each other. CaiHi's goal, and of course, is a bit broader. We're broader than just Ontario, but we really believe that the learnings that we can share through these type of collaborations could be scaled across the country. So with that, I will stop here and see if there's any comments, questions, or feedback for CaiHi.
Hi, thanks. I'm Dan Fernandez from Collingwood General Marine Hospital. Great presentation. Thank you for sharing the roadmap. Firstly, just on this slide, I noticed something at the bottom there with respect to creating sovereign models to test AI. So one of my teams, Health Coding, they submit data to you, data knackers, all that. Are the adequate safeguards for data sharing and abstraction, de-identification, some of the stuff that we talked about at this conference, in place for this sort of work? Number one. Number two, what happens to the ecosystem around coding? So, like you said, private business, 3Terra, for example, a lot of hospitals use 3Terra for data quality.
Yes. Yeah.
Med 2020, which is a vendor, obviously, for the interfacing and abstraction. So what happens to them in this, and are they working with you to sort of embed the AI-assisted sort of coding within these applications? And lastly, before I forget, is I really appreciate the point on serving it back to hospitals to have some sort of benchmarking, maybe even abstract it at a certain level. So I'm wondering how that's going to actually happen. Are you guys thinking about like exposing an API or an SDK or something like that, where we can sort of hit an endpoint and get that sort of safe data, right, curated data back to our data platforms or whatever it may be.
Yeah.
Thanks.
Okay, great, thanks. Okay, so 3 questions. The first question I think is around AI and broader. Do we have the right safeguard and assurance in place to appropriately use these kind of big data in the context of AI? So I would say that's also a piece of work that CIHI and other organizations has been working on. It's well recognized that in Canada, we need an AI strategy, and we need an AI strategy specifically for health data. So if we think about how we're going to, the whole idea of sovereign models in Canada is the idea that, to date, even though we have a ton of data in Canada, they're not necessarily being used. So oftentimes in terms of AI modeling, we continue to rely on studies and models that are based on non-Canadian data, right? When there's so much data in Canada that really reflects our population, our diversity, all of that, right? So I think this is becoming increasingly in the forefront, not just for CIHI, but a lot of our partner organizations as well. And there is now a consortium of organizations that are starting to get together and work on how to advance that. Gemini is one of those partner organizations too, right? But I would say the assurance process probably is not in place, but it's in development, right? And there's lots of probably other use cases internationally that we can look to. So that's the piece of work that's ongoing. To your second question around the coding vendor ecosystem. So yes, we've been in conversation with different vendors, like you mentioned, Met 2020. We understand what 3Terra does, and then there's other vendors that people probably know that is more focused on the AI-assisted coding capability. So not every vendor has it. It probably takes a lot of investment to get into that type of development, right? But we recognize that, and in some ways is ideally, I think from CIHI's perspective, the more vendors there are, the better, right? Because you can have more competition, you have more innovation, and right now the challenge is all these vendors are outside of Canada. So just coming into the Canadian market and customize it for Canadian needs is a hurdle, right? So we're not really in the space necessarily to massage what the market should look like, but we really just want to encourage more products and then be able to encourage these opportunities to trial out the product, identify the gaps, give the feedback to the vendors, and make procurement process a little bit simpler. Okay, and then the third question, I think I forgot the fourth question.
Endpoints. Sorry, it was just around
okay, yeah.
the data flowing back
Right.
into the acute care.
Yeah, so that I think we're still exploring. There's many different options, right? So you mentioned API, and it's one option. We're also thinking about data sharing environments. So nowadays there are safe kind of cloud models where data really doesn't have to move, right? You can access each other's space and take the data you need without actual data movement. So people might call it federated data model or federation approach, for instance. So none of those is out of the picture for us. We're considering all of that because at some point you also don't want huge amount of data moving back and forth, right? That might be the safest and the most cost-efficient way to do things.
Okay, Juliana, thank you
Yes.
very much for that. This is very exciting that CIHI is moving into the future and getting into real time. I think it's news to all of us. I have a question.
Yep.
While we're exploring these assisted coding solutions, there's a feeling that if I help the vendor do this and validate it, maybe they won't need me anymore. I think, can you expand on that point you made about it's not going to replace them, but you can actually do more data quality and maybe we'll have faster turnaround?
Yeah. So, I mean, and this is my own bias too, like I know I work with a lot of HIMSS professionals, and I know that they are not just coders, right? Like they actually have that really interesting mix of expertise that they can speak to clinicians, they can speak to IT systems, and then they have this very focused expertise around coding. So when I talk to my CHIMA counterparts, the idea is right now there's a lot of the coding that is very routine, and you really don't need a human person to go in and code. So take examples. Right now there's a lot of data fields that we abstract into the data knackers that it's maybe date timestamps that people are checking and validating. When a lot of those information we know it's sourced automatically from the HRIS systems, but there's still kind of some practices where people are still going in there, have to find the right information, validate the dates and times, for instance. So those are type of things that you would imagine, like in the future, AI-assisted coding solutions could probably do the bulk of, right? And then it would then free up the coder's time to be able to look at the more complex coding cases, like surgical cases and cancer cases. Although, like there's much more work. Like we're never going to run out of coding work, right? But essentially, is to be able to direct really limited coding resource and coding time into where their expertise are needed the most.
Is there any direction about putting AI Scribe to go the other way, to go from text to structured data that matches the Canadian coding system?
So so there is some conversation about that as well. I know it's out there. People are discussing that because really AI-assisted coding at the moment is imagined as clinical documentation in, and then you do the assisted or autonomous coding. But we also know that for that to actually work, the documentation has to be complete, and the documentation has to be good quality as well. So we know that some vendors are actually looking more upstream and say, well, even like the AI Scribe type model where you're not, the documentation is done perhaps through a ambient listening or scribing type tool. There's some back-end thing to be able to immediately validate, maybe convert the codes and immediately validating against ICD-10 CA codes.
And ask the doctor, is this a bacterial pneumonia?
Yeah, and you can do the quality assurance with the clinicians before the information even then get fed back to the abstracting process, right? So there is that discussion as well, because really, the more you can do upstream at the clinician level, the less needs to flow down to the coders.
That's great. Thank you very much for that.
Okay, thank you.